Today's guest has one of the most unexpected stories in all of psychiatry. She started at the CDC studying immunology and is now a psychiatrist in Orange County. Today's guest is Dr. Sabrina Sandoval from MindCare. Dr. Sandoval, thank you so much for joining us today. I'm curious, you've had such an interesting path between Kenya and CDC, bioterrorism, so on and so forth. How did you land in psychiatry?
Oh, man. Yes. So my journey began pretty young, actually. And I wasn't someone who's like, okay, I know I'm going to be a doctor. That wasn't my thing. But I was a nerd. And science was something that I fell in love with very early on. And I think in high school, especially, had a few teachers. I think that's kind of, we all have those one or two teachers that are like, they're so great. And, they love to teach and you just get drawn in. Mm-hmm. So I had some of those in high school, and I fell in love with biology, in particular, virology. Okay. So the study of viruses, that was my jam. God, so nerdy. And I would run home. I remember this when my grandmother was, when I lived with my grandmother, I'd come home, she'd be cleaning bathrooms and toilets. And I would just go on and on about all the different life cycles of the virus. And she would just, just for hours, and I'm just like, now having children, I find myself with my daughter coming home and just jib jab. I'm just like, I'm like, oh, God bless my grandmother. That had no clue what I was talking about, and would just drone on, right? Yeah. So it's cute, but so that's where it started. And once I graduated high school, actually no, sometime in high school, I don't know, I'm older than you, so you're not going to remember this, but in high school there was both a movie based on real life events called The Hot Zone. Okay. Do you remember that movie? Oh no!
Yes, of course.
Stop it!
No,
you don't.
I'm sorry.
It was called Hot Zone.
What's the
plot? It's a really well written book, and it was just about Ebola. So
I was going to say it's the Ebola outbreak.
Yeah, it was so back in the 90s.
It was the 90s. Yeah.
Thank you.
Yeah.
Where Ebola was a thing, and there was like this, crazy virus in Africa that was outbreaking, and it was sort of like the next new emerging, terrifying, disease.
Super terrifying.
Yeah, super terrifying, because it was a hemorrhagic fever type of virus where you bled out everywhere. You died, right?
Yeah,
you bleed out of your eyes,
your orifices. It was
like a horror movie.
And but
wow, but people were dying fast too.
And it was a time which globalization was a real thing. It was people could just get on a plane and I'm going to from Africa to here, and vacation it's easy, right?
Yeah,
and obviously now it's totally that way now. You can just hop on a plane. With COVID, we saw that, right?
Mm-hmm. Right.
Mm-hmm.
People were just visiting casually in China, a family, and they moved here, and boom, it was off, right? Mm-hmm. So that was the thing back then in the 90s, and I was fascinated by it, and I was in love with virology, so that was my jam. Mm-hmm. And so after high school, that's what I pursued in college. I was looking for places that had a microbiology degree that I could pursue, and so it kind of went from there. And then when I got into actual college, then there was a few courses there that changed everything. And one was medical, I think it was called medical virology or medical something like that. But it was more the application of the effects of these cerern bugs that could affect, how it could affect humans and create disease and stuff like that. It wasn't just like lab stuff.
Yeah.
Right.
Okay.
Because before that, I was all into the lab stuff. I was going to do CDC.
Right.
I was going to be one of those level 4 virus hunters.
Yeah.
So back
virus
then,
hunter.
So cool.
I don't know. See the movies. It's the when you go in and you get the negative pressure.
The hazmat suit.
Yes, the hazmat connected. Don't cut your suit. You're going to die.
Yeah.
Yeah.
I love that. Oh, gosh.
That was what I was going to do.
Yeah.
Wow. I was like, oh, I'm going to do that. And my, of course, my grandparents are like, what? But as I got into when I got into college and I started taking courses in the application and human disease And then interestingly enough, ethics and medicine and law. It's a weird combo, I know, but
interesting.
All those things together, I was like, oh, I kind of want to like go into a field where I can actually help people, not just be in the, like again, in the lab. And then I was like, well, I want to apply that kind of stuff. So that's kind of where the seed for becoming a medical doctor started. So I was already behind the 8 ball a little bit, but that's fine. And then I went into medical school and training with that mindset that like, okay, I'm going to do internal medicine, and then I'm going to major in infectious disease. Because that's that whole global, I'm going to see the weird shit. I'm going to go and find the people who are bleeding out. So cool. But the interesting thing is, you know, you kind of start, when you go to medical school, you're required to rotate in all the different specialties, right? So you get a taste for some surgery, you get a taste for, you know, general medicine, psychiatry, like all these different things. And so when I was going through that, I was like, oh, psychiatry is actually kind of freaking cool. You know, it's not just people talking and theories, right? Yeah. Which is what my early exposure was to it. I was like, I actually really liked it back in high school, but to me, it was like, I was not enough science.
Sure. Yeah.
Okay. And then you come full circle. I was like, oh, actually, there's a lot of science in it, and it's actually now it's fast growing too. So that's how it all came about. And so actually, when I was in residency, or when I was in medical school, I was talking with people about, okay, how am I going to apply this sort of internal medicine to what I want to do? And unfortunately, they said, well, you know, in the U.S., all you're really going to see is 2 diseases. They're going to be like endocarditis and like HIV.
Wow.
And I was like, oh.
That's not fun.
Boring.
I mean, it's not boring. I mean, it's obviously super important, but just wasn't what I was envisioning, you know? I was like, I want the cool, weird stuff. I want to be able to go somewhere and like help put out fires.
And you ended up going to Kenya, right?
I did. So after my first year in medical school, I got a scholarship to go to Kenya.
Wow.
And that was a partnership with them over there. And so in exchange for some students coming here from their program, I would go over there, or there's a few of us that went over there. Great experience too. And that was more of just general medicine and HIV work, actually.
How long were you there for?
A couple months. Yeah. So I lived with the students there, rotated with them, learned a lot about, you know, just not U.S. medicine, right? So, and how they do things there, and then lived away from the actual city. So very, very rural, village type living and stuff, and just kind of seeing how medicine functions and how it's viewed there, and how to kind of bring awareness, you know, to people in villages that were very traditional and maybe hesitant about Western medicine and things like that, and offer things to them. So it was a really great experience there too. So life is a journey. That's what I always tell my kids. You know, you don't need to worry about, you know, what you're going to do now. It may change. Just be open, because my life was never planned out.
Right.
It was always sort of like, oh, that was cool. Let me see that. Oh, that's not okay. And then you just kind of go with the flow.
Yeah. So you ended up getting a master's degree and an MD then?
Yes. So I ended up getting a master's, oh my God, in integrative physiology, which is the nuts and bolts of how cells communicate with each other.
Yeah.
So,
wow.
Yeah. Really intricate stuff.
That's very cool.
Yeah.
Amazing. So now, as you've transitioned into psychiatry fully, right? You're not really on the virology side anymore.
Yeah.
How do you still kind of apply that sort of desire to know kind of the intricacies of whether it's the treatments or the mechanisms of action to the modalities that you're currently offering to patients?
Yeah. Well, it's kind of hard. It's kind of tricky.
Yeah. In
one way. Because when you're applying it to, you know, everyday applications for the patient, I have to kind of be very broad about it. And as you can imagine, all these mechanism of action kind of things that someone like me is really interested in, it's almost so intricate and so many moving parts. It's very hard to explain that to a patient. And for them, for anyone to really understand it.
Right.
It's sort of like, okay, let's spend hours on a whiteboard and let me give you a lecture. So, you know, it's fascinating on one hand to learn about those things and to know it, but it's different to bring it to the patient. So I have to be a little more general and not get too hung up on the details,
Sure.
you know, but enough where they could at least have a grasp of what's going on.
Yeah, science communication can be difficult. But when you're kind of like, I guess, deciding between the treatment that would be best for somebody, let's say with like a treatment resistant issue, like, do you kind of look at I take it the mechanisms of action and like really try to think through, you know, what could be best based off of their current state, or how do you kind of go through that analysis?
Yeah. So I think, yes and no. It's going to be two things you look at. It's going to be what is their experience prior to coming to you, right? So how many medicines have they taken before? What type of medicines? And and in your mind, you're going to kind of scheme out, okay, you've been on 3 or 4 SSRIs. You may have been on an SNRI. You may have been on a little dopamine thing. You may have had some additional medications on that, and you kind of want to see what they've been failing. And then you want to see what the next step is. And honestly, it's a two-way conversation, you know, in my practice. It's like, okay, well, you failed these things are not going to work. I mean, unfortunately, the science shows that the more you fail, you know, and it's hard to tell that to patients, but it's never in the context of like, okay, there's no hope. It's just like, okay, let's look at the facts and let's make a better choice now. Let's give those options. So yeah, I'll have a option, or we'll talk about options, including the new things out, which are, you know, Spravato, which is esketamine treatment for treatment-resistant depression, or like TMS, or even ECT. You know, so I lay the pros and cons of all of it out, and then we make that decision together.
Can you give like a little brief explanation about those treatments?
A brief explanation. Okay, so ECT is something, it's not new. I think we all know that from like the what is it? The Cuckoo's Nest.
One Flew Over the Cuckoo's Nest. Yeah, Jack.
So yeah, we've all heard of it. So ECT, what I tell patients is it's sort of just like a hard reset on a computer. You know, that when you're just, everything's kind of not working right, you don't know what to do, and you're just like, and you hope it comes back on, and you're like, okay, cool, it's all fixed.
Fingers crossed.
Exactly. So that's what I tell patients. Is that's sort of the analogy for that. It is ECT is somewhat invasive. I mean, it's hard to find a provider these days. Actually, usually have to go to a teaching institution like UCLA or UC Irvine to find someone who will actually do it, or who does it anymore,
or be willing to do it.
Exactly.
Because there's stigma behind that treatment.
Yeah, I think it's partially, I mean, I don't know. Yeah. I mean, getting patients to get there, there's a stigma for it, but it's just a lot of red tape these days.
Yeah.
You know, it's not like you just find someone who does it as an outpatient. It's an inpatient procedure, because ECT is inducing a full brain seizure.
Jeez.
So as you can imagine, you want to be in a semi-hospital setting,
right? With
an anesthesia. It requires an anesthesiologist, you know, watching your vitals, how sedated you are, because they're going to put you under. You're not awake for a seizure,
right?
Okay,
right.
So you're paralyzed. You're put under, and then they do a clinical seizure. You know, induce a clinical seizure. That's your hard reboot. So it can be hard to find that, as you can imagine, but it is available, and it is a gold standard. I mean, it works. I mean, it's one of the oldest treatments for treatment-resistant depression. But again,
how effective is it?
It's really effective. I couldn't tell you the numbers now, but it is something that people can look to get treatment for, you know, if nothing else is working.
Would that be like the last house on the block?
I think it depends on the side effect profile that you're willing to accept, right?
Gotcha.
And that always goes into every conversation. So with ECT, yes, it's going to be a little more invasive, more involved, because you will have an anesthesiologist. You will have, you know, paralytics put in your IV, you know, through an IV. And then, you know, like I said, you're going to have a full seizure. With that usually comes some sort of retrograde amnesia, which is memory loss of the day. You know, usually there's some memory loss of that day, like what you had for breakfast, or not remembering what you had in the morning, kind of thing. That usually regain that. But I've known patients to go through ECT who've had a lot more memory loss. So, you know, either further back or just having issues with their memory anyway. So And since I haven't done ECT in quite a long time, I couldn't tell you the numbers now, like how many actually lose a lot of memory. But I will give you a prime example. I'll give you a big star example, which is, oh my God, Star Wars. What's her name?
Leia?
Princess Leia.
Yeah.
Carrie Fisher.
Carrie Fisher.
Yeah.
She had extremely bad depression, like treatment-resistant depression. So she did ECT.
Wow.
And she wrote books, actually, I think. And she was a very big advocate
For ECT?
later in her later years.
Wow.
Who did ECT was the only thing that really worked for her, but she had severe memory loss. She actually, so a part of her writing books is because she couldn't even remember that she was a star.
Yeah.
Can you imagine that? People just knowing immediately who she is and how she couldn't even remember those things. So she would write these books so she would could remember things like that. So, so yeah, with ECT, memory loss is something that's pretty scary as a side effect, you know, and that's going to deter a lot of people,
Right.
as you can imagine. And then we get into discussions like TMS, which is transcranial magnetic stimulation, which is not a hard reboot. It is a much softer, using magnetic waves to just sort of pinpoint areas in the brain. So you're just kind of putting a machine on top of your skull here, and it's just sort of, the waves are just skimming the outside of your brain, so just deep enough, and then it stimulates various parts of the brain.
But it's more targeted than ECT.
Exactly.
Right?
It's a much more targeted treatment. So you're not having a full seizure. You're totally awake. There's really no pain. You come in for 20 minutes, you leave. You could drive.
Don't remember what you had for breakfast.
Remember what you had for breakfast. No memory issues. Really fascinating, actually, type of technology. And I tell my patients about it all the time.
Yeah.
How effective is that?
Oh, it's high up there as well. I mean, probably well over 60%.
Wow.
Awesome.
But it just depends on a lot of factors, you know. It's not going to be 100% for everybody. So
Sure.
And then you get into ketamine treatment, or what we have now that's FDA approved is Spravato treatment, which is esketamine treatment, nasal spray. And that one we offer at our offices, and I have a lot more experience now with that. So we've been doing it at our office probably for about 4 years or more ish.
What's that process like for Spravato?
So the process for Spravato has become much easier, thank God, covered by most insurances. So really the process is just meeting those bare minimum requirements, which nowadays is just, you have to fail, 2 antidepressants. So you've either failed or they don't really work, or you have too many side effects from them. You've done some therapy because they want to see that you've tried these other modalities first. And then once that, and you don't have any medical issues that would be contraindicated, obviously, for your safety. And then it's just a matter of meeting with someone like me, going through the history, making sure you're appropriate, that it is in fact depression, not something else. That you don't have any medical complications that would preclude you from having this type of procedure done. And then we just go and get the approvals from your insurance company. And then once that comes in and we get the medications delivered, then we set you up. So
like, what if I were to get Spravato, like what would that even feel like? I feel like some people say that it feels like a psychedelic. Is it kind of more of a psychedelic experience, or like what does ketamine actually like do to the brain to make you feel better?
Yeah. So esketamine, or ketamine in general, works on the glutamate system. Okay. So we'll try not to
It's
get
like your glutes.
too, like my cheeks. No. So the glutamate system is it's a neurotransmitter in the brain. It's one of the most globally neurotransmitter in the brain, meaning that it's placed or it's active in pretty much every area of the brain. So it's a very important neurotransmitter that helps with the communication between neurons. Okay. So when we talk about depression, we're talking that if you're just going to look at the brain structure, so if you get an fMRI or something like that, it's going to show that the brain is not communicating within itself very well. Those sort of schematics that you see for like the weather. It's blue, it's yellow, it's hot, it's really red.
Yeah.
Same thing. It's the same sort of concept in these images. So if you've ever seen an image of a depressed brain, it's all shaded blue. Whereas you see an active person that's thinking and not depressed, it's got all these different colors that light up, and you can see it working, right?
Right.
So it's actually it's really cool when you look at it, you're like, oh shit, it's actually depressed.
Yeah.
I'm feeling blue.
You can actually see it. Yes, right?
Blue.
So it's just, you can see it. And so with depression, it's basically your brain not functioning well, not communicating within itself very well. And so you get the symptoms like, I'm not interested in anything. I don't want to eat. I don't want to be social. It's hard for me to get out of bed. My energy's low. You know, all these things because your brain is just kind of turned down or not functioning. And so with all these traditional antidepressants, you know, they work on like one, you know, specific neurotransmitter that may or may not work for you when it's dialed up, but for a lot of people it's not. Glutamate is sort of like a big powerhouse neurotransmitter where it goes in and it turns on a lot of different things and a lot of different pathways. So that's how it's different. It's doing a more global turn on, and then downstream from that, it creates a big effect in different ways. So with the main goal of Spravato is allowing your brain to form new neurons, new connections. And so I always talk to my patients about thinking of ketamine as sort of like growing a new plant. Okay. So this type of medication will allow that to happen. So you're kind of like, okay, I want to plant this tree. I want things to grow well. This goes in there and allows new branches to form, new growth to take place. And it actually helps prune too. So you're like pruning away the dead stuff, the stuff you don't want. So I always tell people that it's sort of like, we're going to cut away and prune away all the depressive symptoms or the negative things associated with that.
Right.
And allow new growth in a positive direction. That's, you know, not depressive.
Really good analogy.
Symptoms. Yeah.
I think that like visualizes a very complex mechanism of action with like the brain derived neurotropic factor, right? And the dendrites and like these terminologies that are hyper complex that like are, you know, they don't really land, but it's really just like new roots forming and being able to kind of nourish those parts of the brain that are dormant.
Right.
Or also, like you mentioned, kind of clean up some of the dead roots as well.
Exactly. And that's kind of what psychedelics, or traditional psychedelics do. Yeah. They help with the new growth or new communications within the brains that don't usually communicate. So with traditional psychedelics like, you know, LSD or psilocybin or ashwagandha or, you know, those kinds of things that's the whole, it's one of the main factors. So when you ask me, is it psychedelic like, it's psychedelic like, okay? So your traditional ones, traditional psychedelics do, I would say the effects of it or the high that you get from those experiences are going to be much more intense and a lot longer in duration. And they actually work a little bit differently. They don't work on glutamate. They work on a different type of transmitter system. But when you talk about psychedelics, it's sort of the opening of the brain, and things are communicating in ways that you don't normally communicate when we're just talking or learning about something. Right. So with those experiences, as great as that sounds, you're not going to get, you don't have to worry, I should say, about having those really intense psychedelic experiences with Spravato. So meaning you're not going to, you know, close your eyes and have your heartbeat dictate what you're seeing, which is what they call synesthesia, which is like your senses are blending into each other. So, you know, what you hear is dictating what you're seeing, or a color, or you know, these blending of different senses, which sounds really cool to me, actually.
I have that.
But for a lot of people, you know,
it's scary.
It's intimidating. It'd be very scary and anxiety.
You lose control.
Exactly, and anxiety provoking, depending on just how far you take it. So with the ketamine treatments, no, you're not going to get to that extent. It's going to be a much milder experience than that. So, what I tell patients and what patients tell me is that, yeah, you might get a floaty feeling. You might get a little, what do you call it? Dissociated. Like you don't feel like you're kind of in your body. Maybe you're outside your body. Colors, yeah, they may be a little bit more vivid. Sound may be more intense. And you might have some profound insights, which is great, but you're not going to be on another planet.
Yeah. Subtle.
Definitely.
Yeah, much more subtle.
Yeah,
much more
controlled.
doable. And it's an hour. It's about an hour. So it's about an hour of those types of feelings, and then the second hour you're just kind of coming back down yourself.
Down to the normal self.
So most people don't lose sight of where they're at or who they are when they're having
They
that.
don't lose memory of what they.
Exactly. No
gotcha.
memory issues. No memory loss. or
issues.
anything
Yeah,
like
they're
that.
there. Okay.
Yeah.
I'm curious. I kind of want to piggyback off like the glutamates and how Spravato is, planting that new plant essentially with these traditional antidepressants. I know they've been around for quite a long time, right? Long time. So like, for example, a psychiatrist and my experience, right? Well, let's try Prozac, like throw it at the kind of wall and see if it sticks.
Yeah.
And I'm curious, just from my, knowledge, obviously I'm not a doctor, I'm not a provider, that is only affecting one part of your brain, correct? So like the Prozac is working on like what, serotonin?
Serotonin, yeah.
And so if you, correct me if I'm wrong, I'm curious, if my brain, like my glutamate system is not, like those pathways aren't working and I just throw serotonin in my brain, it's probably not going to work, right?
Yeah. Well, so yeah, this is where psychiatry and science, need to evolve even further, right? So the traditional theory is the monoamine, I guess, depressive theory, whatever, that because someone's serotonin levels are low, that's what creates depression, or that's what keeps someone in depression. And that may be true. So there's, I think it's just more complicated than that, obviously.
Right.
Okay. The brain is way more complicated than just one little thing being off. It's going to be so many different factors that go into that. Is that true for some people? Yeah.
Yeah.
Right. So yeah, because there's definitely people that respond to Prozac only.
Yeah.
There's some people that will respond to Zoloft only. But I think as time has gone on, it's clear that there are a lot of people that is not the case. So traditional antidepressants may work for maybe a third of people. So that leaves so many people out there that don't get a response to those medications.
Right.
That's not the problem. It's something else.
Right.
So I think with glutamate being this sort of global turn on key, that's why we're able to capture so much more people than your traditional antidepressants.
Right. Interesting. Very interesting.
We were discussing earlier with a provider about how environment can have a huge effect on people's depression as well.
Sure.
And I guess I'm wondering, like, at the end of the day, like if someone were to be taken out of their situation and moved to a different environment and had like all of the things that they needed to, help their depression, would that possibly work more than a pill would? It's like kind of like nature versus nurture.
I think
right?
that's a very complex question. Again, that goes back to, mental illness and depression, for example, specifically, it's a multitude of things. It's not just one thing. But the way I view depression is it doesn't really matter whether your depression was caused by an environmental issue or whether you just woke up one day and it's like, I'm depressed. There's a little distinction there, of course. But I don't think at the end of the day that really matters. Because you're both in either situation you're depressed, and now we need to figure out how to best help you get out of that. So a lot of us can have a lot of different things like financial stressors or political stressors, or you lose somebody and then you're like, okay, you kind of get in a funk and you get depressed. But when that depression lingers on for a much longer time, that's a problem. Yes, we all have feelings, and as we should. So we should have those types of reaction to things. But once it gets to the level of sticking around way too long, and then it's hard to function, it's hard to get out of bed, it's hard to get up to go to work, you're not taking your doggy for a walk, you're not doing those things.
How long is too long, do you think? I know it's different for everybody, but
I mean, traditionally they say a few weeks, only a matter of a few weeks.
Wow.
But again, that's going to vary from person to person. How much of your own resolve do you have? How much are you willing to stick it out? How much are you willing to try different things before you turn to help? But I think it also becomes a matter of functionality. So just how much it's actually affecting you and in your daily function is a big one. And then just how far along on the scale are you when it comes to like your depressive thoughts? Am I just a little sad and blue? And, traditionally in a week or two, I'll be fine. And you just kind of deal with that. Or, you go from I'm sad, depressed, and then I have suicidal thinking. I mean, these are all these variables you kind of have to take into account.
Yeah. We've spoken obviously a lot about the biochemical, but I'm curious, like, what other factors do you kind of recommend to your patients, whether it's like diet or vitamin D, or like, what do you think has like the highest return in terms of like a certain behavior or lifestyle amendment, good sleep, so on and so forth?
Okay, yeah. So if if someone's coming to me like, okay, I don't really want to be on meds. I don't, what are the things I can do? Sure. Yeah. You got to look at all the behavioral stuff and what they're doing in their life.
Yeah.
I think I would say one of the biggest ones is going to be social. Being social is probably one of the top ones I think about. Yes, you want good sleep and you want to eat healthy things and you want to exercise and you should be getting vitamin D and going outside. But I think depression is an isolating disease. If anyone's ever had depression before, you get the traditional symptoms of like, I'm sad and depressed and I don't want to get out. But that leads also to, I'm not interested in being social. I'm not returning people's phone calls. I'm not going out anymore. And then you get in the cycle of just, I don't feel well.
Yeah.
And I don't want to go out and I don't want to return those calls. And then that just keeps you there. Because once you get isolated,
it's like a feedback loop.
Exactly. You're just
it's
stuck.
paralyzing.
Yeah. It's almost like you're stuck isolated.
It's extremely paralyzing.
And eventually, you know how it works. Your friends keep inviting you, but you say no too many times.
Yeah.
They stop inviting you.
Right.
And it just becomes, So I would say probably one of the top ones is just being able to.
Community.
Yeah, it's that having that community around you, someone checking in on you, someone, being like, hey, no, we're going for a walk for 10 minutes.
Yeah.
Get your butt up. Let's go.
It's funny too, because I was going to say with social media too, I feel like the idea behind that was to be more social with people and like keep up with your family and your friends who are far away. But I think it's had the opposite effect on so many people, especially with the mass amount of media that we're consuming all the time.
Yeah.
I think
that's nice for you young folks to see that. Because of course.
Oh my God, it's terrible. It's awful. And it's ADHD too. It's like caused, if I don't even know if ADHD can be caused by like something in your environment, but I think honestly, like with devices and screens, it's like you look at kids now, they can't even like play with toys.
Well, or their attention span, like my kids at home. I mean, they're better now, but at one point it was sort of like commercials. What is this? Literally, was it last month? You guys are cheap. You guys can't even pay for the subscriptions, but no commercials. And I was like, oh, hey.
Like, Mom, you're a doctor. Come on.
She's like, hell no. Exactly. But I'm like, no, I did that shit on purpose. Because
you're going to have to sit and wait.
You use those commercials to your advantage. You know what we did in commercial times? That's when you get up and you put your dishes away.
Use the bathroom.
You go to the pod. Yes, exactly. You go to the bathroom. You clean something.
Make a little snack.
Yeah, like, exactly. That's time.
When you take the time.
Yeah. So I will never get the subscriptions that have no commercials.
It's a break. It's a break.
I can't watch something like start to finish like that. I have to take a break.
No, for sure. But I think to your point, Gab, I think technology and social media specifically, they give us the illusion of connection, which is why they're so alluring, right? Because at least we have a face on the screen and we can resonate with their message. But unless we're actually spending that, in-person physical time with the people that we love and care about and that love and care about us, I think to your point, that's one of the biggest variables. And also an interesting kind of thought too is like, how do these substances change your biochemistry, your neurochemistry in a mechanism that will allow you to change your behavior ultimately and be more conducive to collaboration and community, right? Because that's what you're kind of saying is like these medicines are meant to kind of open you up and get you to be able to be more social, right? And to be like more habitual.
Exactly.
So, yeah. What are your thoughts on like how they change your behavior and how Spravato might do it differently than just normal antidepressants?
Well, I think it goes back to the mechanism of action, which is, you know, three main things that Spravato can go and do, but it's the ultimate neurogenesis, the making of these new connections and new nerves that allow for the things you want or the goals that you have for yourself, which obviously is not to be depressed. It allows for that new development so that you can move forward with the things you want to do. So how is that done? All right. So you're going to come in and you're going to get the treatments. Okay. That lays down the framework for your brain to be more open and solidify more of these things that you want. So I do tell patients, look, you're not just coming and getting some squirts in your nose and then you're good. Like you have to do some work. The other things too.
Yeah. And then to that point too, though, like what's unconventional about Spravato is that you mentioned like the social element is a factor. If somebody is completely isolated, they're having to come in, greet a staff member for 2 hours every day, have a dialogue, right? So that has to contribute, even if it's like, you know.
Even if it's just minor.
Yes. They're getting out in the house, they're taking a walk. Yeah.
Absolutely. And we have those patients that's exactly what's happening. Right.
Beautiful.
But besides that, I do tell patients, I like, look, you can't just come get a squirt, go home, sit in the dark the rest of the time. And I think that this is going to work. Like, no, you have to, as hard as it can be, especially in the beginning, you have to try to like open those windows, go outside, even if it's like 10 minutes, you know, take your dog for the walk, do those things. And if they're already doing it, then, you know, I definitely am like, just keep doing what you're doing. It should become easier. And then it becomes not a chore. Right. And you're just living life. That's how the progression usually works. So, there is definitely that other element that I stress to my patients. I'm like, look, you got to make that phone call, you know, try to go out for dinner or something, you know, make your meal today or something like that. Just all these simple things that when we're not depressed, you know, we take for granted. But for folks that are super depressed, you know, getting up and making a meal is extremely difficult.
It's a whole challenge in itself.
It's a torture.
You
know? So when patients do ask me, okay, what else can I do? Of course, we go into this discussion about, you know, obviously sleep and eating, but just doing those things that you haven't done in a while, even if it's small little things like doing your laundry, or brushing your teeth. People don't even brush their teeth. I know. They just brush your teeth, and it's going to suck in the beginning, but as you get better, you will notice that it's no longer a chore. You're just doing them now,
and it pays dividends, you know. And then you get to reap the reward of, you know, nice smelling breath, and then you're like, oh wow, I'm so glad I've put in that effort. But I think that principle like applies in all of life, honestly. You know what I mean? If you have that ability to just have like acute stress and have that tolerance, it actually avoids chronic stress long term, right? It's like the principle behind like taking a cold plunge or something like that, right? If you do something hard, you actually make your life easier. You know what I mean? And I think that what's interesting about Spravato too, and I've done just normal ketamine treatment before, but it kind of makes you realize how much of those things are actually in your control. You know, and the fact that you're still breathing means you have life force, which means you can just like take a step forward towards it. And then you have those dividends paying, you know, like amends in real time. And you're like, wow, okay. And you hit that momentum and that stride. And that sort of paradigm shift ultimately is what I've seen to be like the biggest difference from antidepressants.
And that's what Spravato is giving someone. It's that chance and that opportunity to be like, these small things are going to pay off. I'm going to be able to get and do these things. Because when people are super depressed and coming in, all that seems impossible. You know, like they can't get that inertia going. Like they just can't get up to go even get the mail or like I said, brush their teeth. Like it's, so Spravato gives that to people. I think it's sort of like, okay, you're going to come in. So you're committing. So that's a big step. You're committing to coming in twice a week for 2 hours, you know, which is a big deal. And then we just roll with that and try to reinforce that, we've got to do these other small things. And again, these small things will eventually not be difficult.
No, and I think too, like even just the treatment itself, like obviously, like we mentioned, you're seeing people and having to come into the clinic, but then also you're sitting in a chair, ideally not on your devices, for 2 hours in
Right.
stillness, reflecting on your life,
Yes.
regardless of whether or not there's a substance.
Right.
I think you put anybody on a chair for 2 hours that's depressed and say, don't move and just sit there and just think about your life. They have a lot to think about, and they have a lot to realize
Yes.
about like what's in their control. You know what I mean?
Yes and
And
no.
that's an easy task too for somebody depressed. Sit
well,
down in the
yes
chair.
and no, right? But imagine someone who's been depressed for quite a while, because those are my patients, right?
Yeah.
They've been depressed for, years, decades even.
Sure.
So, to say, hey, just reflect on your life for 2 hours and get back to me is very difficult, because where are those patients going to go?
Yeah.
They're going to go to the gloom and doom, because that's their brain set. Hopelessness, helplessness, I'm never going to get better. So you have to find something to kind of, make that little mind shift in their brain, that little spark, so that they can start going in this direction instead of the spiral.
Yeah, no, 100%. I think that, like you mentioned, like when they're isolated, they're spending a lot of time by themselves at home, but there's like a lot of distraction, they're on their social media, so on and so forth.
Yeah.
But just like being present and then also having like that little spark from Spravato, I think it's interesting. I've never really kind of thought about some of these different elements that might be contributing to why it's so much more effective.
Yeah.
Yeah, well, thank you so much, Dr. Sandoval. It's been a pleasure. You've educated us immensely, and I'm really glad that you made the transition from a virologist to a psychiatrist.
Yes, 100%. You're
Saving
helping
lives.
so many different
Saving people. Yes.
Even if it's not Ebola. It's
If you're not seeing people gushing blood from their eyeballs, at least you're helping people that are suffering with suicidality.
Yeah.
Of course.
It's a virus.
A very important mission, and you're a superhero in that capacity. So
Well, thank you for having me.
Of course, thank you.
Yeah.
And people can find you, Mind Care Services.
Correct.
You're in Long Beach and
Long
Lake
Beach
Forest.
and Lake Forest. Mhm.
You accept all insurances for the treatment.
We accept most everything.
Yep.
Yes.
Yep. And
incredible.
it's incredible that you're offering these treatments, and you've also got 2 other providers that see other patients as well for med management.
Correct. Yeah. We have quite a little group.
Yes,
So,
you do. Yes,
yeah.
you do.
Therapists, medication providers, and
do you
then
do TMS as well?
we had done TMS, yes, for a little while, but we're not doing it currently.
Okay,
Yeah.
cool.
Thank you so much for being here.
Well, thank you so much for your time, Dr. Sandoval.
Thank you. Yes. Thank you so
Thank
much.
you.